I'm Annie Laverty. I'm Director of Patient Experience at Northumbria Healthcare. I think the other thing I wanted to say was, as well as a desire to deliver this afternoon, I've also got a slight unease, I think, about measurement and patient experience. I think patient experience measurement done poorly is creating a reaction for patients who feel, as David reminds me, like feedback fodder. It's also creating an expectation among staff who are chasing around, trying to deliver on numbers without having any opportunity and time to build relationships and improve. So my hope was to tell a different story today within my own organisation. And I've been working there since 1992. And to tell a story of an organisation that has changed, one who in 2007 believed that the sole purpose of the organisation, the number one priority, was delivering high quality, compassionate patient care, to an organisation by 2015 believed that 86% of our staff believed that that was the case. So I was working in the stroke unit late in the summer of 2009, late in the evening, and avoiding a task. So I read a paper that Don Berwick had written on person-centred. He called it Confessions of an Extremist. And in it, he described why he feared becoming a patient in hospital. And I read that paper, and I felt immediately uncomfortable. I popped it in an envelope. I sent it to my chief exec. I sent it to my medical director and the head of our business unit at the time. And I asked the question on a post-it note, together with the paper, what are we doing about person-centred care in my organisation? And I tell that story because clearly it reveals something about an organisational context that is important. I obviously felt it was okay to send Jim Mackey a paper and a note asking with a challenge around what are we doing about person-centredness, speaking up, raising concerns, something that's tolerated well within my organisation. What's not tolerated well is raising a problem and not being expecting to be part of that solution. So by the end of that year, I had a new role. I had become Director of Patient Experience, one of the first in the country, I think, if not the first, and certainly the first linked to quality improvement as opposed to public involvement and engagement. And fast forwarding to 2017, I still wonder why there are so few in the NHS in which we work, where there are so few organisations that have director-level responsibility, board-level responsibility that is solely focused on improving the patient experience as opposed to an additional add-on in exec directors' portfolios. But the summer before I accepted that role, I went on holiday to a very rural part of Turkey. I live with an ecologist, so we tend to go far from the town. And on the last day of our holiday, his parents had joined us, and I persuaded him to leave our children with their grandparents. I said we'd hire a couple of motorbikes and we'd head to the hills and pretend we were 20 again. I didn't get very far. I drove into the back of a fruit lorry, and I woke up having been unconscious in the back of an old ambulance in a rural part of Turkey. All my innate prejudices came to the fore. There was no bit of me that believed that what I was about to experience was high quality, safe healthcare. I was terrified. I arrived at a brand new hospital. I was taken from the door and almost immediately to a scan. I had had my scan within 20 minutes of arrival. I worked in stroke services, and I knew in my own organisation that door to scanning time wouldn't have come anywhere close to that. I was transferred to HDU. I was their first patient. There were 5 nurses who were desperate to provide some care at that point. And the ratio was 5-1, and I knew that didn't seem to me anything like the ratios that I'd left behind, or indeed the ratios that are currently on our wards at the moment. So the care I was immediately receiving, and all of the indications were very positive, and yet I was too frightened to let go, too frightened to trust and receive the care that was being offered. And that evening, a gentleman came to see me and explained that he had no medical background at all. He said, actually, my background is in the hospitality industry. I'm working on reception. He said, but my English is excellent. I'm imagining you're pretty frightened tonight. I can come and see you every day, and if you've got a question, I'll ask it on your behalf. And it was that point that I let go. It was that point I started receiving the care that I needed to, and I will be forever grateful for what was a small act of kindness, but the impact was massive. I came back determined to measure the things that mattered to the people that were on the receiving end of care. And I went to my chief exec with an ambition of how I would hope to do that. And so my original thoughts was devising a measurement system that was focused around the things that mattered to patients whilst they were in hospital. What I didn't think clearly enough about was how much that measurement, how much that feedback, how much that reality check would actually mean to staff who were trying every day to provide the best care that they could. I've heard a lot today already about the building of communities, the power of people, the focus and the importance of relationship. And my belief is that patient experience measurement done well allows us to really scrutinise the quality of relationships that exists within our institutions and feed that back so that we can all respond and improve that relationship for the better. So there are lots of definitions out there about what compassion actually is, but for me it's about three things. I wanted to build a measurement system that allowed us as an organisation to pay attention, to notice the things that were going on around us every day. For that to evoke an emotion in our staff, noticeably empathy, but a desire then to act on that emotion and do something swiftly with it. And there is a wealth of evidence out there that organisations that pay attention to that way of working, pay attention to the quality of the patient experience, will achieve better clinical outcomes and indeed will be safer too. So for the remainder of the presentation, what I wanted to do was just focus on 5 key things that I think we've learnt to pay attention to. And the first, and this has been also mentioned quite a few times today, is the importance of leadership, but leadership at all levels of the system with a focus on the right things. So within my own organisation, creating a framework where people using services, staff and other key stakeholders can come together to actively agree what our quality priorities are and then how we've done with that plan each year. To have that performance reviewed at every level of our organisation and very explicitly and transparently shared. And again, the reminder from Chris today at the start of today about the majority, the best quality ideas and the majority of the good innovative ideas will come from the end user. So having solutions that are patient-led, clinically led and around frontline change, stuff that we knew would be important. This is a bit of a reality check for me. This is work done to improve surgical site infection. Infection destroys lives, leaves people with a very different future at times, and families often without loved ones suddenly. So important work. The reality for us as an organisation to deliver that change and indeed sustain it required us to come up with 25 and more different ideas to test. wasn't just one big idea, and it required 20 different teams to come together and create that outcome, and it took us time. So no quick solution, no one hero stepping in, and no one quick idea. Staff in our hospital have, I believe, a need, and if we are to keep them engaged and a focus of improving services, they need an understanding about what they offer every day. They need a coherence around what their plan is and how it fits in with the wider plan of the organisation. We need to be willing to step back and listen to their great ideas for change, their creative solutions. And we need to be humble enough to do that and not think that the solutions are ours and they pass down through the organisation. And we need to create the very environments that increase our opportunity for building relationships and increasing contact, not doing the opposite, not taking staff away from the very people that they want to be spending their time with, that give them joy. An outstanding organisation, apparently, according to the CQC, but the reason I put it up here is it reminds me of the difference between seeking buy-in to a solution and actually seeking ownership. I was proud of this, not for the accolade, but actually because I knew that the staff and teams working with patients and communities had delivered this for the organisation, and the fact that they knew that too. So we spend a lot of time each year gaining insights from patients and families about ways to improve care. And we haven't found one way of doing that. We've needed to rely on a number of different methods and measure a number of different points of care. We get feedback from more than 50,000 people every year. We speak to 700 people every month in real time, and that's fed back. When I say in real time, I mean in real time. It's fed back within hours to our teams. Something like the ownership of that feedback when you're on duty to hear yourself talked about, your contribution talked about in the free text data, to make you really responsible and accountable for that. And if that's celebrating everything that you did that day, there's a motivation to turn up and do the same tomorrow. As well as the gaps in care that exist in our organisation that we are walking past every day, we are also walking past excellence and an opportunity to really celebrate the contribution that everybody's bringing to a common cause. We have that information shared right across the organisation. I'm going to flip through some common slides and you'll see how that's shared at an organisational, a site, a service level, individual, ward and consultant level. But it's not only been about the numbers, and it's not only been about the data, or believing that the solutions for that lie within our own lens. We've worked with third sector organisations, asking people with learning disabilities to help us understand how accessible our outpatient services were, help us reduce non-attendance in dentistry services, with the simple use of photography, which laid out what they could expect in a visit. Inviting older people onto our wards as a third lens, really, to a fresh pair of eyes to help us understand the experience of people with dementia and delirium on the ward, the opportunities we were taking to promote dignity and those that we were missing. And that fed back again in real time to teams who could then learn and respond. However uncomfortable that feedback can feel at times, we've learnt that the fastest way of getting better will be to share that information widely across the organisation. So all of that data, the numbers, the free text comments are on our hospital walls, outside each of our wards. The red poster there that you see is celebrating our top 20 docs based on the ratings and the feedback that their patients gave them last year and compared with their performance this year. This is a definition, an 83-year-old's definition of what dignity is. I've yet to read a better one, but we adopted that definition of dignity, and we can, hand on heart, understand the variation in dignity across all of our teams, and then act swiftly to improve that. So you could choose your theme according to what's important to you and understand it. This is the sort of report that our consultants will get at their appraisal. It's outlining their feedback against questions that we know, based on PICA research, are the questions that are most positively associated with the most positive experience in hospital or for outpatient care. And then that performance compared with all of the other consultants within your specialty, no longer acceptable to be technically just good at what you do, but an understanding that the quality of the relationships that you promote contributing to that experience fundamentally. And we've learned to understand change and measurement because we know that that lies at the heart of improvement too. So the principles behind our measurement were that we wanted it to be swift. We needed it to be not on a multitude of things. It wasn't going to be about the 65 things that you had to do better by next month, but the handful of things that you could count and respond to. So actionable things that you could own, specific things that would matter to the people in your care. And above all, we wanted it talked about, promoted, discussed across the organisation, and we used every means to do that. We've become a safer organisation over time, working in partnership with patients and families. We've become an organisation that offers better patient experience and have gained a national reputation for doing that. At an organisational level, on each of those core domains that matter most to patients, I went to my first exec meeting when I just got the job, and I mumbled something about, I was really out of my comfort zone. My stroke family were up on the ward and I had no mates around the table, and I mumbled something about I didn't think that our measures were very responsive or person-centred enough. And the chief operating officer at the time said, "That's fine, Annie, if you want to come with your person-centred evidence-based metrics by next week, we'll be sure to listen to them." And I sort of scuttled out the room. And in that week, Don Redding, bless him, he's not in the room now, but he was working in PICA at the time, but he published a paper on the views of what 72,000 people cared about while they were in hospital. And he defined it in 7 core domains. And I rang him and said, "Look, you don't know me, but you've just completely saved my bacon." They became our metrics. They were a handful of things we could pay attention to. They were things that people cared about. And we could measure them relentlessly, week in, week out. Each of our wards was visited twice a month. At an organisational level, every single one of those domains statistically better than they were before. Our performance in national patient experience surveys, when I took the role on in 2009, we were ranked 111th in the country. Last year we were joint 10th with Newcastle. And the 9 organisations above us, specialist hospital, who are inviting a different patient experience, it could be argued. We opened a new emergency care hospital. We're able to understand, based on feedback from thousands of patients, about a change in the system and what that's meant at a patient level. All of those things statistically better within a year. We've gained more trust, clinical evidence that the care is safer, and people also talking about increased likelihood to listen, improved diagnostics that make us better at handling pain, and overall trust in the system better. If you're an orthopod and not convinced, or if you're an orthopod who deeply needs that, we've spoken to over 8,000 people. That was 61% of the available patients at the time of those interviews. And we can understand the difference between an elective procedure and what it feels like to suddenly experience trauma with regards to a sudden hip fracture. At a ward level, twice a month you'll get a report which will measure those core domains. We don't ask you to to think about what the ward next door is doing. They're caring for a different group of people with a different group of team to respond. Pay attention to your own patients, your own team. Think about what your baseline is and try incrementally to get better. All the improvements you make this year get rolled up and they become your new baseline for the year ahead. So the focus is on continual improvement. And our staff have come to really love the figures, but they love this stuff even more. So with every report, every comment that's made about that team is recorded and fed back in real time, within hours. Sarah, the occupational therapist, for example, gets noticed and appreciated. The domestic team that are working tirelessly to keep our hospitals safer, for the first time they mentioned in board reports. They wouldn't have been talked about previously in terms of the contribution they make to an organisational endeavour. We've learnt a lot from stories, but a plea for stories done well. Because stories told come at a price at times. People revisit painful experiences, trauma in hospital, the loss of loved ones. And so rolling out stories at the beginning of something without a commitment to do anything about, in fact, committing to any measurement programme without the obligation to do something with that information, something we've learned is very important. But we know how emotionally connected our staff are to the stories they hear, and we've relied on both. And we've learnt to get really serious about celebrating compassion and kindness, and it's those stories across the organisation that reveal that. So just to sum up, as I said I would close in about 20 minutes. These are some of the things we've learned. The soft stuff isn't soft at all. It's sometimes hard to do well. It's certainly hard in terms of impact. And you need to understand what motivates your teams and frame it in a way that you can all move together towards a shared purpose and a new way of working. And I think that was what we've heard a lot about so far this morning. We've learned that it's not a choice between just stories that engage the heart or hard data. We've relied on both to convince us. And having a system that relies on values and reminds us of the behaviours, the relationships that underpin quality have been really important. We've made tiny little steps along the way. This is not a short journey. We've been working hard at it for 6 years. And we know that we need to keep doing that. The opening of the new emergency hospital means we have to pay particular attention to a new model and flex and change and adapt as that organisational story changes. But above all, instead of immersing our staff in a pain of just measuring for measurement's sake, we've tried to free them up so that they can find the joy in improvement. And for us, that's been important to protect above everything else. So I'm going to stop there and